Next, we're going to talk about imaging the equine posterior segment with the smartphone. This is the reason that I first became interested in using the iPhone for looking at the eye, taking a photograph of a horse. 2010, I think it was, when I first got my iPhone, and pixelated pupil. I noticed that I could suddenly see the fundus, and took the phone all the way to the cornea, and to my amazement, the fundus appeared. And for the last 10 years, I have been passionate about trying to spread the word that it's possible to examine the equine eye using just our iPhones, and to find techniques to make us do it in a better and better way. So, just the rest of the eye, I think when we image any part of the patient, trying to have it as part of a story is very important, so you don't have images in isolation. So I try and think of either a story which is related to the pathology or the history, or even simpler, just the path of light from the outside world to the retina, to try and help us understand what we're seeing. So key to understanding how we use the phone to image the retina is, I guess, is understanding what direct ophthalmoscopy is compared to indirect ophthalmoscopy. We need to learn how to ensure the light is on continuously, and how to alter the intensity so we can get different effects and also make it more pleasant for our patient. It's important to be able to get close to the patient safely, and to be able to manipulate our phone close to the equine cornea to get the best images. We're often only 2 or 3 millimeters from the surface of the epithelium. And also to think about the way we hold our phone to maximize that, depending whereabouts the LED, the light and the camera are. So on the corner of your phone, the middle of the phone, you need to hold your camera in a different way. And then specifically, we're going to think about how we image the optic nerve head, the tapetal fundus, and the non-tapetal fundus, because we need slightly different techniques for each of those parts of the fundus. So first off, visual axis. It's just to remind ourselves of this very simple but useful technique, concept, which is the corridor of light from the outside world through the cornea, aqueous lens, vitreous, to finally hit the area centralis, the area in the centre of the fundus where most useful visual information is recorded. So in a horse with a big eye, we can't just look to document the visual axis. It's not just a single view. We specifically look from the front of the eye, so nasally, temporally, superiorly, inferiorly, and axially, to try and document each of those five views, if you like, back to the back of the eye. Before we go on to the retina itself, the fundus, we'll talk about the vitreous. So vitreous pathology we see in our patients, both normal and abnormal. These can be cysts, such as this horse here, or vitreal degeneration or hemorrhage, or occasionally other more unusual things such as foreign bodies or parasites. So to look at the vitreal base, we have to look very obliquely through the cornea, and often, rather than a still image, a video is much more useful for us. There's an example of a video of a horse with posterior inflammation and lots of vitreal degeneration, and the still image we can see on the left shows us there's an opacity, but the video shows us the anterior vitreal base in a much more dynamic fashion. So we often use videos to document the vitreal changes. This is we met this horse earlier. This is a horse in total ground detachment and a retinal tear. So again, we have to alter our views to examine the large intraocular area of this horse. So these are sort of images we hope to be able to get that when there's a clear visual axis and nothing impeding a view. This is a Cremello horse. Normal equine retina, one of my favourite equine funding photographs. So we talked about direct and indirect ophthalmoscopy. Direct fundoscopy is what we would call close direct ophthalmoscopy, what most of us are used to in the horse. So getting close ophthalmoscope close to our eye, using a direct ophthalmoscope and getting close to the horse. With our ophthalmoscopes, we give a beautiful view, lots of detail, but very small field of view. One of the disadvantages of this technique is any opacities in the visual axis will reduce the quality of the image dramatically. We also need to be very close to the cornea. The alternative way of looking at the fundus is indirect moldoscopy, which is the modality of choice in small animals, less widely used in horses, but prior to using the iPhone to document retinal pathology, I would have used that a lot more than I do now. It gives a very wide field of view and therefore thus less detail. But it does, however, cope very well with opacities in the visual axis and does need to be done from a distance. Probably one of the last photographs I have of using the lens to image the equine fundus. And what I used to do was, using a lens and a video camera, we'd use this to video the indirect view to show to students while we were teaching and to record pathology. So in the small animal, it's still a very, very useful technique. However, in the horse, we rarely use it now. And that's one of the reasons for that is the field of view. One of the advantages of the lens is it gives a very wide field of view compared to the direct ophthalmoscope. When we use our cameras to image the lens in the same manner as a direct ophthalmoscope, if we're using the wide-angle lens in our cameras, we suddenly get a wide-angle view. So we can get the same field of view with direct ophthalmoscopy, looking at the fundus, as you would do using a diagnostic lens in the small animal, for example. So direct photoscopy, can give you some examples. And again, this is trying to explain how we want to try this as part, use our images as part of a story. This is a horse with an eye assist, and we're examining it prior to removing it, and we're examining the fundus as part of the examination. But by taking a series of moving pictures, stacking our images, we can actually see that the cyst casts a shadow over the area subtralis in a way that the granular doesn't. And in this particular horse, those behavioural abnormalities consistent with it being aware of the cyst and it moving abnormally during exercise, and then following removal of the cyst, those behaviours resolved. So these images help support our supposition that the cyst was clinically significant in this horse. The still image in the bottom left is a beautiful image. You can see the vessels very clearly. You can see the ganglion cell layer as it starts to become myelinized as it comes close to the optic nerve head. We can't get that same feeling that of the shadowing we see in the moving image. So when we're telling our story, we're going to start off with looking at the visual axis, which is what this shadowed GIF is telling us, I guess. So we're going to light on. We're going to get nice and close to the horse. We're going to zoom in so it fills the eye, and again, work and actually document a clear visual axis before we get close to the eye. We're then going to bring the phone close to the eye, so we can actually start to see funny detail. We can see the stars of Winslow beautifully. We can see that shadow. We can see the optic nerve and the edge of the optic, the physiological cup of the optic nerve head very nicely. This is another illustration of how multiple images can give us more subtle information. This is an older horse. It's got a butterfly lesion, an area of inactive chorioretinitis adjacent to its optic nerve head. The right-hand image shows that beautifully. Well, the left image shows us additionally is this horse has got nucleus sclerosis. And as we look through very, very slightly different angles, it distorts the view of that optic nerve head in a very subtle way, which helps us to document the effective nucleus sclerosis in this patient. We've got Esquimalo already, and it's just a few examples of the sort of images we can get. This is normal hypermyelinization next to a normal optic nerve head. So how do we do it? What's the technique? So when you first start, many of your images will look just like this. Most of my best funding images were not taken in unstated horses. We routinely, for our first examination of any of our ophthalmology cases, would sedate them, use tropicamide to dilate the pupils, and an AP block to stop them blinking, and hyaluronic acid to lubricate the cornea and keep it transparent. whilst we photograph the fundus. So this is a horse who's awake, unblocked, and undulated, and we're obviously getting a glimpse of the retina past those lovely lashes. So sedation and nerve blocks, for us anyway, are going to be, and undulation will be routine part of all of our eye exams. Technique is very important. We control the light. So I prefer the Pro Camera app, which is shown in the bottom right corner. You can see there's these 3 bars that allows us to reduce the light intensity of the LED. If you haven't got that app or that functionality on your phone, then we have to add in a diffuser. So we can reduce light either by putting something over it, a diffuser. We use micropore tape, so 3 layers of micropore tape, or 2 medicine labels is usually enough to dim the light sufficiently to get a good image of the eye of the fundus, but not dazzle the patient. You can also move further away from your patient to reduce light. That doesn't work when we're imaging the fundus, however, because we need to get as close as possible. So visual axis, we want to explore that before we document the, actually look at the fundus itself. So we're using distant direct, and we're looking at different angles to make sure we see a nice clear visual pathway, so to try and understand what this horse is seeing of the world. Then we're going to use our distant direct technique to use our cameras to record those clear visual axis or any opacity if they're there. And then we're going to move to the fundus. So to get to the fundus, we're going to move the phone closer and closer to the eye. We need to focus at infinity. So your phone will do that automatically if you tap, but if you're struggling to get a good image, if you force the camera to focus at infinity, that will hopefully give you a clear view of the fundus. And you can see how close we need to get to the horse's eye, using my hands resting on top of bottom either side of the eye, and then my camera is resting on my 2 hands to allow us to get super close. So you can see in this left-hand image, we're probably less than 5 millimeters from the surface of the cornea when we are at our closest. You probably will be aware of the fact when you're using a direct ophthalmoscope to look at the horse, that when you're probably 12 inches away from the horse, you can start to see the optic nerve, but you also start to see lots of iris and eyelid. And you see the same happens with our iPhones. This isn't a horse, this is an alpaca. And from a distance, I would say 6 inches, I can actually see the optic nerve, I can see the iris, lots of eye. As I move closer and closer, I see more fundus and less adnexa, and get closer again, I see more fundus again and still see some of the iris, until I get, this is the money shot, this is the one we're looking for, when the image fills the entire screen with no adnexa seen at all. This is when we get our optimal view of the fundus. When we've got an image of our fundus, then it's not all plain sailing, because we've often got a dark non-tapetal fundus, a hyperreflective or a reflective tapetal fundus, and then this intermediate white to pink optic nerve, and each one of those will need exposing in a different way to get the best picture. So tapping to focus and tapping to expose is a useful way of doing that. So I've tapped on this optic nerve head on the screen. That's allowed us to then alter the exposure to optimize the exposure of the optic nerve head. So it's the same eye, either tapping on the edge of the optic nerve to see the optic nerve in focus, or in the non-tapetal fundus to expose for the non-tapetal fundus. And you'll see the optic nerve has become much whiter as exposures being increased to give us more non-tapetal fundus detail. And in this left-hand photograph, even more extreme, we've actually seen lots more non-tapetal fundus detail, but the optic nerve is now whited out because it's overexposed. A few case examples. This is a horse with active chorioretinitis. Eventually this will turn into an enormous butterfly lesion. And just to show you that we're trying to focus in different parts of the eye. We're focusing from the tapetal fundus in one way, non-tapetal fundus in another way, the optic nerve in another way. And those pictures together give us the overview of the whole pathology. This is what it looks like. This is using the Pro Camera app. And we are bringing the phone close to the eye. And we can still, we're not quite close enough, we can still see iris. On the left-hand side, you can see we're manually focusing. We can focus at infinity. This particular app has what's called focus peaking facility. So it does digital zoom into the center of the image. So when we're trying to focus, it will let you really fine tune your focus to make sure you're focused correctly. This camera also has both a telephoto and a wide angle lens. So the 2 times you can see over here is when I switched to the 2 times telephoto lens, and that's given us a much closer view of the optic nerve, which is important for documenting those fine blood vessels. The optic nerve head itself, so we need to focus it for its piece of focus for it specifically. Lots of very important pathologies going on here. You can see the left-hand image we're exposing for the non-tapetal fundus changes in these bullet lesions, and the right-hand image we're focusing on the optic nerve. I've deliberately put this marked up image in to remind me to tell you that if you take a picture on your phone, most apps now will allow you to mark those images up. So you can take an image of a picture of a fundus, and you can scribble on it, and you can then message that to find a friend, your local ophthalmologist or colleague, and ask them what they think the green things are or the yellow things are. So marking of images is very helpful. Just another examples of images where they've been marked up to say, well, what's going on at the yellow area is the physiological notch where there's no blood vessels. The green areas show some physiological hypomyelination, and this white area here is an area of normal albinism. And similarly, the blue areas is actually a normal horse with no pathology at all. Finally, before we leave the fundus, one of the things that I can only ever see with my phone is the nerve fibre layer. So this is another alpaca. We can see these white areas are myelination of the ganglion cells as they arrive at the optic nerve head. You can see those with the normal ophthalmoscope. This is a horse at the edge of the optic nerve. This lovely wing shape here, this grey area, is the same thing happening as the ganglion cells arrive and become closer to the optic nerve head. They start to pick up myelin, and we see this beautiful wing shape, which I can only see with the iPhone, because the angle between the light and the camera is just slightly different to that in the ophthalmoscope. It's another example of the nerve fibre layer. And a final one, this beautiful wing shape, which is normal and a sign of a healthy retina. That's the optic nerve head, non-tapetal fundus. This is the 3 pictures of the same horse's fundus, and we've exposed it in 3 different ways. The left-hand photo is exposed to show the non-tapetal fundus, the middle one exposed to show the tapetal fundus, and the right one is exposed for the optic nerve head. So we need to take several photos of the same part of the eye. We can get incredible detail with our phones in this way, as long as we expose them correctly. And then tapetal fundus. Tapetal fundus is in the horse when the retina becomes thin, will become hyperreflective. That hyperreflectivity is much less marked than it is in dogs and cats, who have a different sort of tapetum. Their tapetum is made from crystals, whereas the tapetum of the horse is made from a fibrous layer. So one way of trying to demonstrate tapetal hyperreflectivity is to take multiple images and then to stack them together, and you can see this shimmering effect, which really highlights the areas of retinal thinning, which are much more so than the single image on the right hand side. This is my favourite I'm not sure my favourite funding image is, but it's a beautiful funding image, and it's just to remind me that the retrobulbar block, it is possible to perforate an eye with retrobulbar block. I've done this on my own patients, thankfully with an enucleation, but a very beautiful picture of the atypical fundus as well. I think that brings us to the end of our talk about imaging the eye with a smartphone. So thank you for your attention, and please keep in touch. If we can help in any way, please contact us, and we're always happy to help. Thank you.